Good morning and welcome back again. So I will be talking on, is the practice of ECMO different in India? Having seen the practice elsewhere for a couple of decades, and when you want to inculcate the same values with the same sort of results in our country, is it possible? This might apply to other centers in the developing world which are trying to embrace this technology and organizing the program by adapting it to the local needs of the population. So I think this adaptation is extremely important, where we have to work together by sharing our experiences. ECMO is a preventive strategy for preventing lung trauma and maybe to cardiac myocardial damage as well in case of cardiac failure. It is supportive but not curative. This is the underlying principle. The basic criteria, referral criteria, probably do not differ a lot, but there is something additional consideration which we need to look into while going for ECMO practice. Mostly it should be reversible, cardiac failure or respiratory failure or cardiorespiratory failure, and there should be no contraindications for limited heparinization. The gestation of more than 34 weeks is taken into criteria for avoiding intraventricular hemorrhage, and cannulation becomes too difficult as well if the weight is less than 2 kilos. Ventilation and high pressure and high FiO2 for less than 10 days. So as it was emphasized this morning, the most important is the duration of high pressure ventilation and not the total duration of ventilation. In our country, or in resource limited countries, our infections form a major indication for deciding about the need for ECMO. ARDS as a final common pathway, it should be reversible, and cardiac reasons, prolonged cardiopulmonary bypass where the patients are unable to come off or needing some sort of surgery, for corrective surgery after inadequate surgery during the time, or myocarditis. These are some of the reasons when ECMO might be helpful for cardiac reasons. And non-cardiac, we just discussed what snake bites, scorpion stings, etc. and poisonings as well. But it is very important that ECMO should be initiated at the right point of time. So I always say, just like ABC first, get the conventional management right. That is most important. ECMO is not for a disease which can be cured by conventional management. Think about ECMO only if the conventional management is failing, but the trick is it should be done at the right point of time. In resource limited countries including ours, probably a referral process is taking a long time at this stage. It depends on the awareness of the program, awareness of the facilities over there. Ideal time to go on to ECMO, when should we consider that? My point of view is, once you approach an ECMO center and discuss with an ECMologist regarding the need for ECMO, we are simply not placing them on ECMO. If there is a contraindication, we decide on it, or if there are ways to make the patient's life better, we suggest those ways as well. Because the conventional management does differ from a critical care physician to an ECMologist who practices it from day-to-day basis. Distances are a major problem in the country. We will talk about transports, critical care transport, how it is being organized at this stage, at a later stage in this conference. Financial burden, to me it looks like this is a major problem at this stage, with public organizations like Central Institutes and Armed Forces Medical College coming into view. Probably it might open a new era. And this presentation by Vivek was an eye-opener as well. Critical care transport within the country is very important. One or two centers for the entire India do not work. They are not intended to be done that way. So there should be a roadmap how we are going to organize this by developing specialities. Similarly, 5 to 10 centers within one city are not good either. The collective experience takes it down that way. If there are more centers, then the number of cases reaching those centers will be coming less and less. In our country, still most of the times it is road transport. Probably you can cover a distance of 400 miles or 600 miles on that. It takes long period of time and precious time will be wasted on that. Air transport would be good, but how many people can afford to that one? 1 hour of air transport costs around 100,000 rupees per hour. So with that, the cost problem for the patients will go up higher and higher, financial burdens. Probably the best way to go forward is developing mobile ECMO service. You can go to the center, you can fly to the center with the equipment you have got with you, put the patient on ECMO and bring them back. You take your own time while bringing the patient back. I'm talking about by road. Tomorrow, later on today, I will be talking about train transport as well, train ambulances later on. But at the moment, it would be road transport for majority of this period. You can fly the patients as well, depending on their financial implications they are prepared to face. This is one of the patients in Krishna Institute of Medical Sciences where I am practicing right now. There should be adequate space for the patient and adjacent instruments. When any center is planning for this, you can see the patient over there along with infusion pumps, ventilator, CRRT in this as well, and there is an ECMO pump which is partly hidden by the CRRT mission. So it needs a huge space as well compared to jam-packed areas. It is not advisable to do it that way. There should be enough space. The ECMO unit, in my opinion, it is something which is capable of providing complete care to the patient. Like all modalities of ventilation, understanding the ventilation and applying it to the patient whichever is needed. High frequency oscillatory ventilation, which is more proven in the neonatal and pediatric populations, maybe to a lesser extent in adult population, inhaled nitric oxide, etc. They should be available in the center as well, because ECMO is still the last modality when none of the conventional measures work. Environment, I just highlighted. Infection free. We shouldn't give any new infection to the patient. Treat the infections, but there should be very less chance for acquiring new infections, especially the hospital acquired infections. Expertise of the team will depend on the single person cannot do this. Always it is better if you are doing it as part of the team. However small the other person might be, a perfusionist with lesser experience or a nurse who is learning as well. Always there is something to learn from that, a minute thing which might add up. One of the differences I faced over here compared to Western countries is, while I was there as a teamwork, I look after the patient for a week and hand over to my colleague. But we can't do that here. We are responsible. Once you have accepted the responsibility, you are responsible till whatever happens to the patient. So carrying the responsibility with you all along is another big aspect you need to be used to. And keeping the skills alive, it does come with more and more practice and attending training programs also. I feel infections are a major problem in our country. Cross infections from different patients, that is also very important. So hospital policies have to be modified for the betterment of all our patients with zero tolerance to infection. How do you make it more affordable to people? Probably in corporate setup, as they are prepared to come forward and accept this technology now, maybe giving some sort of package. How much does a week of ECMO cost around 2 weeks of ECMO and then additional costs like that. As we discussed earlier, the cost will be higher during the first week and especially on the first day, because much of this is disposable equipment, and afterward these are running costs of ECMO. So probably formulating some packages in the private setup might help in reducing the cost down, and using it as an option as well. If there is a cardiac program which is being offered for a certain price, maybe for slightly additional price you can include ECMO also in that, in case the patient needs. So if the patient doesn't need that bit, that can be used for the next person. Cannulation depends on availability of the cannula. I spoke about availability of the Avalon cannula in our country, as it is not available, but efforts are being made to make it available to resource limited countries as well. And Central also has been very helpful in this regard. How do you cannulate? There are plenty of ways you can do that with semi-Seldinger technique, open technique, percutaneous technique. Whatever you do, most important is securing the cannula. That is the most important. Cannula migration does happen, so be very careful that cannula remains in place. We are reaching this sort of conclusion, like tunnel lines are probably better for preventing the infection and also the cannula stability for both aspects. Our surgeons are also thinking of inserting a Gore-Tex patch, especially for the arterial cannulation. So the forward cannulation, as well as for the limb, putting a graft back for the reverse perfusion of limb, that also becomes easier with Gore-Tex graft. And securing the cannula effectively, that is extremely important. Monitor the position daily. That is also another important point, because cannulas tend to move with the movement of the patient. One positive aspect I found over here is the zeal and determination of the people who believe in doing ECMO. It is a team effort, and without team effort and each one of us helping each other, we can't make progress. Pruning is a very important part of the ancillary treatment. It helps, but there are difficulties. With the size of the patient being bigger, it becomes difficult. Smaller children, neonates or pediatric population can be pruned easily compared to adult patients. But even in those cases also, taking care of cannula, I do suggest putting the patient to the right side up or left side up, because the postural therapy has a lot to do for betterment of your patient. How often is another question. It depends. During the daylight hours, please do that when majority of the people are around, and when minimal support is available in the night time. Don't venture to do lots of heroic things at that time. One of our patients being pruned at Krishna Institute of Medical Sciences. Money matters. They are really important, because ECMO doesn't come free or without money. There are ways we can make it cheaper and cheaper. I think passion is very important in making it affordable to the common population. Ancillary services expenses, they do add up. For bronchoscopy, bronchoscopy is therapeutic on ECMO. You have to do the suction. So for that sake, bronchoscopy and clearing the airways, having a look inside how the lungs are progressing. So this is almost therapeutic. We tend to do it on alternate days at our center. One of my advices with respect to suctioning is, because suctioning the airway is so important, our inline suction really doesn't work that much. When you have to do proper suctioning, it has to be regular suction and not inline suction for clearing the airways. CRRT also adds up, because you have to initiate it at the right time. You cannot wait for too long. Once the patient is overloaded with the fluid and becomes like a balloon, it is really too short. So try to keep the patient to the basic weight, and you have to monitor your fluid balance on a daily basis. The treatment and support from multidisciplinary team is extremely important with this, and information and inputs from microbiology and other laboratories, they are of paramount importance as well, because you have to diagnose infection at the right time and treat it accordingly. One of the challenges I place over here is, despite the fact you explain everything about ECMO, relatives are concerned, is he going to be okay? You talk to them for half an hour also, till the ultimate question is he going to be okay? So even after explaining so much about the risks and benefits of this as well, because of the closeness within the family, what they are interested in, after spending this much, is my patient going to be okay? So that much of assurance sort of 100% assurance people will be expecting from you. The survival, it depends on so many factors, on the disease status, on the age group, immunological condition, types of bacteria they have got, types of funguses, superbugs they have already acquired, at what stage of the disease they are, cardiac, respiratory. So there are multiple factors affecting the survival, and it is time critical as well. It is not unusual. Despite the fact patient is being at your own institute, it becomes sometimes few hours for you to decide the finances, get some sort of assurance from the organization, mobilize everything and put the patient on ECMO. Can we equate timings with outcomes from other centers in the world? Probably not, because our resources are different from what other people can afford in different parts of the world. Learning from the mistakes is very important, sharing the data anonymously so that we learn from each other and we don't repeat doing the same mistake once again, and become members of ELSO, Extracorporeal Life Support Organization, which confidentially shares your own, monitors and shares your own information and gives the international information to you as well. That will be very, very helpful. The price is nominal, so I encourage all of you to become members of ELSO, so you can monitor your program as well. Over the years, as I just look back, I think the mindset of ECMologist is really a different one compared to critical care physician. We don't want to quit. Every day you have to gain your own energy. Am I doing the right thing? Is the patient getting better or reaching an irreversible state? Every day you have to look at this reversibility between reversibility and irreversibility, and optimize everything. Critical care is a balance at the end of the day. Focus, do the permissive strategies when required. You can't aim for 96% saturations all the time. Maybe if the tissue metabolism is okay, you should be okay with the 80% saturations or 85% saturations as well. Look for the venous saturations and lactate values, looking at the tissue oxygenation as your priority. So take action. This might result in success or failure. The entire team will be happy if you are winning, and there might be windows of opportunity for you to come off. Patient may not be 100% right, but there might be a window of opportunity. Your lungs are recruited enough and you might be able to support them on conventional ventilation, so come off. So this is a continuous process of balancing multiple systems and making sure that you are doing the right thing. So that is the mindset of an ECMologist in my view. All of us are artists. Critical care is an art. In my opinion, Ravi Verma is the biggest artist for me and a perfect artist for me from Indian point of view. We're all at different stages as artists, so it all depends on us with the wealth of experience we accumulate, how perfect we are going to be in this art of critical care. Permissive hypotension, permissive hypercarbia, permissive hypoxia, they do come in the management strategies when you are going through your ECMO process. Indicators of tissue perfusion are very important, as I mentioned earlier. So the end result in some of the centers could be, or most of the centers could be, the reputation. How can we guarantee the outcomes? That becomes a major problem. So concluding my talk, the goals are the same in the developing and developed world, but there are plenty of hardships for us to face in this part of the world. Travel times are still a question, and we need to explore further ways of tiding over this process. Infection control is extremely important and dedicated staff are required. I would like to invite all of you to the second annual conference of South and West Asia chapter of ELSO. I'm sure you all are aware of us being South Asia and West Asia chapter of Extracorporeal Life Support Organization. Nearly till a couple of years ago, ELSO was limited to American ELSO and Euro ELSO. They had recognized the need for expanding the ELSO further, and there are another 4 to 5 branches of ELSO or chapters of ECMO which have been opened now with designations like Latin American ELSO, Asia Pacific ELSO, South Asian, West Asian ELSO, like that. So we belong to South Asia and West Asian chapter of ELSO. We have 27 countries in this jurisdiction. We held the first meeting this January in Hyderabad, and the next conference is going to be at Narayan Hrudayalaya, Bangalore. The stalwarts like Bob Bartlett, Steve Conrad, James Frantenbury, Ravi Tyagarajan, Peter Rikas, they are all coming to grace this occasion along with our colleagues from West Asia. So I invite you to make use of this opportunity, which is very, very